Hi, everyone. Thank you so much for joining for another round of AJOG MFM highlights, this time for the May 2026 issue. I am Mhatre. I'm a maternal fetal medicine specialist at Tufts Medical Center in Boston and the director of the MFM Fellowship at Tufts. And as always, welcome to the editor-in-chief of AJOG MFM, Drs Berghella. Vince, so nice to see you again.
Hi, Mo. Happy Friday.
Happy Friday. So thanks everyone for joining. For those who are not familiar with our format, we select 4 articles that we want to highlight, and I've listed them here. These are papers that we feel have a rigorous study design or are clinically relevant, and ideally not only just to our MFM colleagues, but also to all of the providers who care for patients, pregnant patients in the clinic or on the labor floor, and we're really hoping it's going to be clinically impactful for your care. We are using visual abstracts, some by the authors and others made by me, by myself, and to have a high overview of the paper, but we strongly encourage you to read the papers in detail on ajogmfm.org. And with that, Vince, why don't you get started with the first one?
Yeah, the first one is a systematic review and meta-analysis of randomized trials, and this is provoking. It's looking at high-dose preconception folic acid supplementation, in this case 4 milligrams compared to the usual low dose that we tell everybody to take, 0.4 milligrams. And as you can see there in the lower part of the graph, 3 randomized studies were included. And at the end, they actually showed 27% decreased incidence of miscarriage. That relative risk is 0.73, so that equates to a significant 27% decrease. I know we all don't do that, and I was unaware of this data, and I think it's nice to review and certainly provoking. I'm not going to change my practice maybe as of today, but certainly this is something that maybe patients should be aware of, make their own decision, and maybe more data in the future, hopefully.
Yeah, very interesting paper. The next one I want to talk is another discussion of other medication exposure, specifically for acetaminophen use in pregnancy. We've heard a lot about this recently coming up in the media, and especially with the some of the discussions that have been coming up recently with the current climate in the United States, but specifically about, what is the evidence available about safety for acetaminophen use in pregnancy? And this was a review in AJOG MFM this month. Some of the things that we know right now is that really the exact mechanism of action of this medication is unknown. There's a number of theoretical pathways that Tylenol or acetaminophen may cause its effects, but we do know it does cross the placenta. And there are some animal studies that are suggesting some downstream effects from this transfer. And there are also a number of systematic reviews and meta-analyses of observational data that were suggesting that there is some neurodevelopmental issues from exposure of acetaminophen in pregnancy, particularly with autism spectrum disorder and ADHD. But a very rigorous study that was done very recently showed that in sibling match studies, those effects were not seen. And so I think that there seems to be a number of genetic and environmental factors that also play a role in the development of neurodevelopmental outcomes that we need to be mindful of. And so this paper was talking in really nice detail about the different methodological limitations of the studies that were included in the meta-analyses that were suggesting a possible link. Really, the key points are that the case for causality between acetaminophen and these adverse outcomes is weak at this point. There are a lot of limitations in how those studies were designed or the heterogeneity of the studies included. And also importantly, we are treating pregnant patients who are in pain. Also, we know that fever is not a good exposure to the developing fetus. And so we have limitations about what medications are available to pregnant patients. So based on all of the available literature at this time, acetaminophen remains the preferred option to treat fever and pain in pregnancy when medically indicated. But as always, we as prescribers or providers should be recommending the lowest dose for the shortest duration possible. And I'm sure more data will come in the coming years. But a really nice review of the existing literature and kind of where to go from there.
This other one looks at enhanced or really group prenatal care. It's an analysis of the Embrace randomized trial looking at the pregnant Latino population, low-income individuals in California. Really, the RCT was targeting social determinants of health, which is so important, and seeing if that even further enhances group prenatal care. And the bottom line is that in this study, which is not the biggest one, but it is randomized, in this subgroup they could not find difference in their primary outcome, preterm birth, mid-gestation age of birth, or attendance. I personally love social determinants of health. I think that they are big drivers to preterm birth, among other things. And so I'm looking forward to more data on this. I'm sure it was disappointed for the authors. Nonetheless, negative studies need to be published, and hopefully this will kind of be the incentive for looking at how to best address the social determinants of health, group prenatal care, and prevention of preterm birth. We do know that group prenatal care decreases preterm birth. It's just a matter of finding out how we can best support people with social issues to further decrease preterm birth.
Yeah, really excellent work, and more to come with that. And I agree, a negative study, but also a very important study to highlight and hopefully launch something bigger. The final paper we wanted to present was a paper looking at universal third trimester ultrasound at 36 weeks in low-risk patients. And so, right now, it's not recommended in the United States to perform a late third trimester ultrasound in low-risk patients. I believe it's more common in Europe to do that quite frequently. And this group wanted to see if you had a patient who otherwise did not need a 36-week ultrasound. One, would you find anything, particularly the four major components were FGR, an LGA fetus, polyhydramnios, and oligohydramnios, and could you identify the particular maternal demographic risk factors that would say, okay, actually, this is the reason we should do a scan? If they looked at some age, race, height, BMI, parity, and tried to identify if any of those factors were the case, or is everyone actually at high risk of having one of these four ultrasound findings? They evaluated 661 patients. It was a secondary analysis of a larger study. And what they found is 22%, so about 1 in 5 patients of these low-risk pregnancies had one of these 4 findings on ultrasound at 36 weeks. They could not identify a single demographic risk factor that had a higher chance of finding an abnormality on the ultrasound. And the authors use this data to support that we should be doing routine third trimester ultrasound to identify either abnormal fetal growth or abnormal fetal fluid volume that would otherwise be unidentified in these reported low-risk pregnancies. So I think it's very interesting. I would be curious about the cost of this, especially in the United States. I think of a high chance of potentially false positives, but there's some benefit. Sometimes there's third trimester diagnoses that can be detected and change plans for delivery and things. So I think really thought-provoking, and I'd love to explore this a little bit further. And that's a wrap for this month. Thank you again, everyone, for joining us. Vince, always great to see you. And we'll see you guys in June. Thanks again. Have a great day.
Thanks, Mo. Have a great day, everyone.